The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridge Ed in their entirety. This is the FlightBridge Ed podcast, critical care and emergency medicine education for nurses and paramedics.
Hey everybody, Eric back with you. Today I have a good friend of mine, Mark Piehl, Dr. Mark Piehl. How you doing, buddy?
I'm good. It's good to be here.
Well, we have tried to do this podcast for 3
years. Or 2 or 3 years.
2 or 3 years. Like it seems like our schedules always collide. We're always on the road in different locations.
So I decided to show up at your office at the world headquarters of FlightBridge Ed and say we're going to do it.
And we're drinking bourbon.
We are. Blanton's even.
Yeah. Well, we just did a podcast with Peter Antivi. You're a good friend, a close friend.
Mm-hmm.
So we're going to have a little fun today. Right? We're going to talk about the same topic, but in kind of a different context and talk about maybe your perspective and what you're seeing and try to hit on areas maybe we didn't hit on with Peter. And so excited to have this topic. Really, the focus of the month of July is obviously trauma, and people are out there doing stupid things, getting injured. And so I think blood product administration is such a big topic in the industry right now. I know you are one of the physicians that are helping lead the way around the globe. And so love having you here. I want you to introduce yourself and let's get started.
All right. Well, thanks for inviting me out, Eric. Total privilege to be here. And yes, trauma, and in particular pediatric trauma, is probably my favorite clinical topic. So I'll enjoy this conversation. Hope you will. And so I'm a pediatric ICU doc in North Carolina at a hospital called Wake Med in Raleigh. And I also serve as one of the medical directors for our critical care transport team, Wake Med Mobile, which is a privilege for me to do as well. And just for disclosure, also am the inventor of the LifeFlow, which is a device that many agencies are now using to give blood, and that accidental invention arose out of my experience with a pediatric trauma patient who died, for whom we felt we provided inadequate resuscitation. And she ultimately kind of changed the course of my thinking about trauma and ultimately of my career and the directions I wanted to go in education, research, and innovation.
It's amazing when we come up with ideas. It's usually based on our maybe some failures. If we're humble enough to recognize that.
Right.
And we recognize maybe an area that we could have done something better, or maybe it's just a missing cog in the wheel in the system, right? And then you figure out a way to fix that problem. And I think that's where a lot of businesses start.
Right.
I think it's amazing though to have a product or have a solution to a problem that impacts so many people. So I love it. When we think about blood product administration, I think Peter hit on this real well, really started seeing this come to life in around 2015-16. I know in this area in Kentucky, when I flew for Air Methods, that's when we started carrying blood products packed for blood cells and plasma. So what is your involvement really from a local area at Wake Med, North Carolina, and then talk about maybe your involvement nationally?
I mean, my clinical environment is the trauma bay, the ER, the ICU, and indirectly through my transport teams. So to be clear, I'm not out in EMS agencies giving blood. I've learned what the need for urgent resuscitation is as I see a patient come into the trauma bay in distress, in shock, and have been involved in developing some of our protocols and how we manage that better. And kind of as I mentioned, one of those patients that we flew in ultimately bled to death in our hands. And I thought, we're just not good at this. From the street, from the scene, to the aircraft or the vehicle, to the trauma bay, to the ICU, we don't recognize and treat hemorrhagic shock quickly enough. And in kids, that matters potentially even more, because once they decompensate, there's not many minutes to spare. And so I just developed an interest in thinking about how do we do this better? How do we provide effective resuscitation when minutes truly do matter? And that's basically any patient in hemorrhagic shock that you encounter out in the world.
So what data is out there that really drives this, right? We're so focused industry-wide on evidence-based practice, on making good decisions. Now, we can get into a whole topic on what type of data are we looking at. Are we looking at observational data, which is very common? We can gain some insight there, or is it an RCT, a meta-analysis? But just for this discussion, what's driving these decisions?
I mean, I think you and I both know, Eric, and everyone listening to this podcast knows intuitively that someone's bleeding to death, they need blood given back to them. So we don't need probably a lot of evidence to prove that point. But where to give it, how, what type, how fast, what adjuncts, those are questions that remain open. I think, as Peter mentioned on your previous podcast, a lot of the early data that we've relied on in the civilian world has come from the military. In particular, Dr. Shackelford's study called Medevac looked at combat casualty care and showed that soldiers who got blood early, within 15 minutes, were much more likely to live than those who didn't. That was one of the first studies in my mind that taught us, wait a minute, we need to make those early minutes matter. And then subsequently, there's been a number of studies published, many with plasma. We can get into that, Eric, at some point, plasma versus packed cells versus whole blood, showing that, yes, we can impact mortality by getting blood products into patients with hemorrhagic shock earlier. And then I've had the privilege of working with some EMS groups, including the team in New Orleans, on publishing data out of their system where they enacted a program of packed red cells, calcium, and TXA. They called that Advanced Resuscitative Care Package, or ARC bundle, for patients with penetrating trauma and hemorrhagic shock. And they, out of great kindness, and I'm privileged to have been a part of it, invited me into helping write that study. And we published it last year and showed for the first time ever that blood products given in civilian urban EMS agencies can improve survival. That's never actually really been demonstrated before in civilian EMS. And they showed that patients receiving blood products with hemorrhagic shock and penetrating trauma compared to those who didn't get blood products were much more likely to live, up to 90% survival in those patients who got blood products. And so that, in my mind, started the trend of data coming out showing that earlier resuscitation in the field matters. And subsequently, we've seen from a good number of agencies, again, that Peter mentioned in your previous podcast, Atlanta, DC, South Florida, a number of other agencies showing around the exact same survival for patients with severe injury plus shock, getting blood products in the field, have about a 90% survival. So I think both published and now anecdotal evidence are showing the trend towards improved survival with early blood products. But to be clear, there aren't randomized trials yet.
Right.
And I know there are some calls for it. I don't believe that we have equipoise on this topic anymore. I don't think we can do a randomized trial of blood versus no blood. I think we all intuitively know that it works. We just need to figure out the nuances of what type, how much.
Do you think you can even get IRB approval for something like that?
You might. There's some folks at several academic institutions that have called for RCTs on this. Yeah. I don't know, Eric, but I think it'd be tough to do it.
Yeah, it's almost an ethical thing.
Yeah.
I mean, yeah. So that goes into the topic of, there's a lot of things I want to ask you. So let's just jump right into the topic of whole blood versus plasma versus PRBCs, access, just everything that you know and feel about those areas.
That's a lot of topics to cover.
Yeah. Well, we can start with whole blood.
I'll just build on my friend Peter's comments with you in the previous podcast. I think we all probably agree that whole blood is the optimal product. Someone's bleeding to death, they bled whole blood. Let's give that back. Let's give the product containing oxygen-carrying red cells, clotting factors, and platelets back to them, and fibrinogen, all the good stuff that's in there, 100%. But you and I both know that's really tough. It's really tough to get whole blood in many jurisdictions. And blood banks are increasingly making that more difficult. So some, to be fair, are making that possible, but other places the finances don't line up. It's hard to do. So I'm a believer in whole blood. The hospital-based studies are showing, we think, that whole blood versus component therapy, component meaning plasma, packed cells, platelets, is producing better outcomes, more survival, and less total blood product use. That's what we all want, right? But should you, if you're an agency thinking about implementing a pre-hospital blood program, should you wait until you get whole blood, or should you go forward with something else? And I think the answer is the latter. So the New Orleans studies, in those studies, they used packed cells alone and nevertheless showed dramatically improved survival. Some of the plasma-only studies, Pamper in particular out of UPMC, did also show survival. Remember, that was mostly air medical.
It was, yeah.
And a lot of interfacility transport. So they're
Correct.
not the exact same patient set.
Agreed.
But nevertheless, plasma is probably better than crystalloids, and we will agree on that as well. We're seeing good success in several agencies who have said, we want to move forward, but we don't have access to whole blood. Let's just make whole blood out of plasma and packed cells. I love that. I love that idea. That's what we've done in the hospital for years. A massive transfusion is ideally a 1-to-1-to-1 ratio.
Correct.
Packed cells, plasma, and platelets. We're not going to give platelets fast in the field. They're hard to access. We probably don't need to carry them, but giving equal amounts of plasma and packed cells to your bleeding patient, I think, is a really effective strategy. And thinking of Cobb County, Georgia in particular, who has a dramatic success with that program. And they, to their credit, move forward with their blood program despite not being able to obtain whole blood. So I think, just to summarize, whole blood is great. If you can't get it, go with component therapy until you can get there. And as Peter mentioned, we are going to see freeze-dried or spray-dried plasma on the market, we think, in the next year or two. And that will be an option for agencies that cannot get cold-stored plasma or packed cells. So that's going to be another way to get into the business of providing blood products early in the field.
So expanding on that, I know you deal a lot with those. We talked about this off the show. Talk about the rate of administration, and let's talk about transport times. Just you have an agency that comes to you. Well, let's just imagine you have a small 3-4 ambulance agency, large county, large service area. What do you say to that EMS administrator, medical director of selling blood product administration as part of and getting the coolers and
yes?
What do you say to them?
So Eric, I guess one of my favorite lines right now is minutes matter. Every minute matters. And so you may remember from one of your conferences I spoke at a year or two ago, I told a tale of two agencies. One in which the transport time from the trauma scene was 40 minutes, and one in which the transport time from scene to trauma center was 3 minutes. We probably would all agree, yes, the patient who has a 40-minute transport, boy, they really need some blood because it's going to be a long time until they get it. But that patient, in the scenario I discussed on the stage at Fast 24, was a traumatic arrest. He needed blood in minutes or he was never going to make it alive. And he got it. He got 2 units of whole blood within about 5 minutes. He got ROSC. He survived. The other argument I hear, especially in urban agencies, including some of those near you, is that we're too close to the trauma center. Just get them to the trauma center. We don't have time to give blood. And that one probably makes me even madder to hear that argument. Okay? As if those 15 minutes in the field don't matter. And as if the minute the paramedics bring the patient through the trauma bay doors, a bunch of magic starts happening. Everything right happens within minutes. We know that's not true.
Yeah.
We've wasted all that pre-hospital time of the provision of good critical care and resuscitation that pre-hospital teams can do so well. And so in those situations, and including the patient from DC Fire that I mentioned to you, within a 3-minute transport, the patient shot multiple times in the torso with hypotension. And by the way, penetrating trauma plus hypotension equals about a 50% risk of mortality. They were able to infuse 1 unit of whole blood. She went from a GCS of low 8 to talking, blood pressure from 60 to 110. She enters the trauma bay in a totally different state, and her pathway is different. Everyone can think clearly, decide what the next intervention or diagnostic should be. And she has been in that many less minutes of shock, that much less tissue damage has been done. She's a much healthier person that you bring through the door who's much more likely to live. So I think the argument in both rural agencies and urban agencies is the same. Minutes matter.
And I think that's the area when I talk to these EMS directors and I try to sell this. You got to have a system in place. You have to have medical direction. We talked a bit about this really in the pre-show conversations of medical direction, forward-thinking medical direction, understanding evidence-based practice, being willing to continually grow. You also have to have administration that's willing to spend the money.
Yes.
You got to be fiscally responsible. I get it, right? Margins are really tight. Reimbursement is very difficult in EMS. I get all that. There's always that argument of saying, well, we might only help 2 or 3 patients. And I get that. But that's also 2 or 3 patients that we could save. And so I think that's a hard thing.
It's hard.
I see either side. I see either side. I think you have to have a good training program in place. I think you have to have good structure in place. You have to have a foundation in place. You can't just deploy blood and coolers and the whole aspect of keeping temp. You can't just do that with every agency. There's got to be, your ducks have to be in a row. And so I think that's important. But I would agree with you. I think barriers of entry, not knowing how to access blood product, is a huge thing. And looking at the overall, it's overwhelming to people because they don't know what they don't know.
It is. And Eric, you're right. There are many barriers. They can be overcome, but there are many barriers. And Peter and you did a great job of outlining them yesterday. We can go through them again if you want. But I'll try out a theory on you, which is, one, I think the cases of blood administration you're going to have that will present to you are more than you think. So many agencies think we're going to do this for trauma. But then what about the postpartum hemorrhage? And the elderly patient on Eliquis who has a nosebleed? And the child who has a tonsillectomy and bleeds out several days later? And the gastrointestinal bleed? You name it. There are a wide range of conditions for which pre-hospital blood administration can improve outcomes and save lives. The theory I have is that as an agency goes through this process, they become better at everything because it's such a laborious thing to go through.
Yeah. Protocols
have to be developed. Clinical skill improves. We have to assess carefully that patient before we administer a precious product. There's almost a reverence about it. Okay, am I going to give blood or not? And I believe the teams get better at everything they do in that they became providers of effective trauma care. And so that's just a theory I have. I can't prove it to you.
Yeah, I love that.
But I think it's team building. I think it's clinical skill enhancing across a range of diagnoses, not just that involve blood. I think it makes the whole agency a better agency and helps them provide better care across the range of the conditions they encounter.
Well, it shows iron sharpens iron.
Yes.
Right. Yeah. I love that. So let's talk about plasma. Mm-hmm. Let's talk about plasma. Is plasma something that you think we should be giving? Like if you don't have whole blood, you have plasma, you have packed red blood cells. Do you think plasma should be first? So Peter also mentioned one of the fathers of pre-hospital blood transfusion, who is Don Jenkins, former military surgeon, now in San Antonio. And in correspondence with him, he said to me, if you had the choice, I'd give the plasma first. Okay? I'm going to disagree with him. Can you give the rationale, what his rationale was?
Yeah. And there's a good rationale for both of these choices. Plasma, one, it's a volume expander that doesn't leak out of the endothelial tissue. It produces endothelial repair, meaning the lining of the vessels has been shown to be healed and repaired through the administration of plasma. This is why it may be good in TBI and sepsis and a variety of conditions. So a patient who's lost half their blood volume has diminished cardiac output. There's not enough oxygen carrying red cells getting around to the tissues, right? So if we give plasma, we improve that volume, we send more blood around. But that blood doesn't contain any more red cells than it did before. It's just more of it going around. So that alone can help the patient for sure. But my theory, and this is in part based on the packed red cell blood data from New Orleans, is that if I could choose, especially early in the resuscitation, I want to give more oxygen-containing volume, oxygen-containing red blood cells. And that not only expands volume, but gives me more oxygen delivery to the things that matter, the heart, the lungs, the brain, the gut, the kidneys. And that the heart may even paradoxically work better because it's got red cells and more oxygen going to it. So my choice would be, and there's some good science behind this, if you have packed cells and plasma, I'd give the packed cells first, get that oxygen delivery improved, and then augment with plasma for clotting factors and additional volume. That's just one guy's opinion, but that's what I advocate.
Well, interesting. One of my nerd subjects, obviously, the oxygen delivery formula, DO2 is equal to CaO2 times
all that if you want.
Cardiac output, right? You got to have hemoglobin.
You do.
And that's the biggest impact.
And if you do the calculation 1-to-1, plasma versus packed cells, you get more oxygen delivery per volume with the packed cells. That's intuitively true.
Makes sense.
You get even more because the heart starts working better because it gets more oxygen.
Right.
So if you have the ability to give both within minutes, why not give the packed cells first?
Let's talk about how do we deal with these patients that you respond to that are in traumatic arrest?
Yes.
Do you work them?
Yes. So again, I'm not claiming, Eric, that I'm an expert on this topic, but through the agencies I've had the privilege of working with, and that's now approaching 100, we are seeing probably in every agency anecdotal cases of unexpected traumatic arrest survivors. There's too many for it to be a fluke, okay? And so I have begun, and you heard me speak about this at your last conference, to try to refine some criteria by which we think it may be possible to produce a traumatic arrest survivor. We know that it's infrequent, it's unlikely, but are there a subset of patients who through early blood transfusion close to the point of injury can nevertheless survive? And I think the answer is definitively yes. And the subset who I believe is most likely to survive are those who have a witnessed arrest by the team or within a minute or two of their arrival. Mm-hmm. So they haven't been down that long. And by the way, what is traumatic arrest? Is it PEA? Do we see a rhythm on the monitor but feel no pulse? That heart's still probably trying to beat. So I prefer the term pulseless hypovolemia, meaning that heart really wants to produce cardiac output. It just doesn't have enough blood to do it. It's trying and trying and trying. How can you know that? You can pop an ultrasound probe on and you can see the heart trying to beat. If that patient has zero cardiac activity, I think the likelihood of them surviving is close to zero. If the heart's beating, yet I feel no pulse, that heart needs volume, that it needs blood. So the patient with a witnessed arrest who has some evidence of cardiac activity and ideally has a compressible injury, meaning something I can put a tourniquet on, a junctional tourniquet, a regular tourniquet, a direct pressure. I'm not saying those are the only ones, but it seems to me to be the ones who are more likely to survive. We have a couple blunt trauma with traumatic arrest survivors that I know of who responded to a couple units of whole blood. So I think it's possible. I don't think everyone needs it. The criticism of using blood in traumatic arrest is that we would waste the product. They're so unlikely to survive that we'd waste the product. So through the efforts that your own group is doing to try to improve pre-hospital ultrasound, for example, there are ways that we can begin to, I think, triage the patient who is more likely to survive. But we can't do it without blood, Eric. And the latest NAEMSP, ACEP, and surgical guidelines that just were published on trauma arrest do highlight a number of effective interventions that we can target, but they didn't include blood as one of them. It's not anywhere in the document. It's just published.
Seriously.
It's not there. Now, To be fair to the authors, it's because there's no published data on it. But we're going to have to push the science forward.
Right.
And we are seeing a good number of trauma arrest survivors who get blood in the field, and I think that's going to change the entire way we approach that condition.
You bring up an amazing point. I don't know if you heard the recent podcast that Weingart and Sam Galli did on PEA, right? And Sam's amazing, right? They're both amazing, but he was talking about how many patients that are in PEA that we call that if you put a probe on, they still have cardiac activity. Yeah, right. We just don't have enough pulse pressure to fill a pulse.
Right.
So I think that was a big deal.
And there are a lot of causes for that potentially, but one that is entirely reversible is hypovolemia.
Right.
Right. Think the H's and T's.
Yeah.
What are the H's and T's? Hypovolemia is one of the first H's, and a patient who's injured most likely has hypovolemia from hemorrhage.
Yeah.
And so I think we can correct that. I'm not neglecting tension pneumothorax, tamponade, other things that we can try to treat in the field, but giving volume first, I think, is with blood products, I think is the new approach to traumatic arrest.
What's your go-to view if you're looking for cardiac contractility? Is it going to be subxiphoid or peristernal long?
I think either. I think the easiest one to teach probably is subxiphoid, especially if you've had CPR ongoing. There can be subcutaneous air. There can be broken ribs. It can be harder to see the heart.
Good point.
So I think a subxiphoid is probably the optimal view, and it takes a lot of practice to know what you're looking at. I'll just throw that in as well.
Sure. Well, we talked about your good friend, Peter.
Yes.
Love him to death.
As do I.
What arguments do you have with his podcast?
Why are you asking me that? You're setting me up.
Yeah. He'll enjoy this.
Yes. So I'm thankful for Peter as a friend and a partner in much of this pre-hospital blood work. We've worked together for many years. I've learned a lot from him. We have, with a number of other incredible providers, founded a course called the SPARC Academy, the Selective Pre-Hospital Advanced Resuscitative Care Academy, where we teach pre-hospital providers about a circulation-first approach to trauma care, meaning you've got to have blood available to you and treat the circulatory problems first with hemorrhage control and resuscitation. And Peter is on the leading edge of many things, including rolling out plasma, as he mentioned, for a variety of conditions, including sepsis and TBI. I think they're very promising studies that he's involved with, and they're showing some good outcomes. I think the two, and he and I've, just full disclosure, he and I have discussed this before. The two arguments I'd have is, number one, I would probably prefer pack cells first if I had the choice between plasma and pack cells.
Right. And I think you made that argument pretty
Peter
well.
rightly points out that agencies may be reluctant to implement any blood product because they can't get red cells or whole blood.
Yeah.
Why not go with plasma first? Maybe plasma is the gateway drug to whole blood. I like that argument.
Argument of saline versus yeah.
So, but that's the second one. Is there a role for crystalloid in trauma patients? And you will often hear, never give a drop again to a trauma patient. That's where I would argue a little bit. Most of your listeners are not going to have a blood product on their truck, right? Or in their aircraft. Well, sure. many more will have them on their aircraft,
right.
But especially ground agencies are not. What do you do with a hypotensive patient and all you have is saline? Particularly if they have a traumatic brain injury or a spinal cord injury. I think the answer is you give them crystalloid. That's the volume expander you have, and we know from EPIC TBI, well-done studies out of Arizona, that allowing those patients to be hypotensive with severe TBI increases death.
Sure.
So let's resuscitate them.
Okay.
However, the caveat is never use LR with traumatic brain injury. Why is that? So this is some nerd physiology here. LR has a sodium content of 130. That's hypotonic. What do we want to do with severe cerebral edema? We want to give a hypertonic solution, like 3%, right? Saline is 154 sodium content, essentially hypertonic. That's what I want to use in any patient for whom I'm giving volume expansion with a crystalloid who has a TBI. Number two, a child an injured child with hemorrhagic shock who is hypotensive is likely to die. The single biggest risk factor for death in pediatric trauma is hypotension, number one risk factor. So if you encounter a child in the field who's already hypotensive, you're not an agency who carries plasma, packed cells, or whole blood, what are you going to do? You're going to give them 20 per kilo of saline. And I can say that definitively.
Sure.
I think Peter would agree with me on that one as well. We can't let a child remain hypotensive. What volume? 20 per kilo, maybe 40. In an adult, 500, maybe a liter. I don't want people to go away from talks that they hear at trauma conferences thinking I should never give a crystalloid to a trauma patient again. In general, that's true. For years, we have given too much, particularly in the ICU, maybe in the pre-hospital space. But there is a role for it in smaller quantities in urgent situations. So those are the only two arguments I'd have with my friend.
And I think we've really focused on, I know with my teaching, whether it's burns, sepsis, make sure you need fluid before you give it. Do 500 at a time, reassess your patient, be cognizant of why you're giving what you're giving.
Yeah. And Eric, here's a role for ultrasound, which I think is underappreciated. You put the probe in the subxiphoid position, the IVC is flat, the heart's banging away, that patient is hypovolemic. If it's burn or sepsis, they will tolerate the volume and they will likely respond to it. It's your job then to see, did they respond? Oh, did the heart rate come down? Did the blood pressure go up? Did the perfusion improve? Did the end tidal come up?
Right.
So volume tolerance is something you can learn from effective, quick ultrasound view. And likely volume responsiveness.
Let's talk about really quickly some endpoints of, hey, we're going to pull the trigger, give blood products. I know
such a good point.
Peter talked about this. What I want to talk about really, and we didn't really expand on this in the previous podcast, is let's talk about shock index. And I want to talk about shock index not only for adults. I think that's something I cover pretty well. I wanted to talk about, is there a role for shock index in pediatrics? What is that? What's considered a permissive hypotensive number, right? I know 60 is the number we always hit, but in penetrating trauma in younger adults, is there a lower number? And what is that in pediatrics?
I love this topic. So, first of all, there is no such thing as permissive hypotension in pediatric trauma.
Okay.
We should not target that.
Okay.
Now, I'm sure some surgeons will argue with me, and I'll be happy to have that argument. Remember, hypotensive child from sepsis, anaphylaxis, hemorrhage is at risk of dying. We need to fix that hypotension. The concept of permissive hypotension comes from an era where we gave a lot of crystalloid for resuscitation. So the theory was you give a lot of fluid to try to normalize the blood pressure, you dilute the clotting factors, you chill the patient, you make them more acidotic, and you disrupt the clots that they have tried to form internally. It's counterproductive. So the idea of permissive hypotension was give just as much volume as you need to achieve some minimum systolic pressure. And I think if you look at the TCCC guidelines, that's somewhere around 80 systolic. Okay. What should that number be in a child? Let's put that placeholder on that for a second. What we've seen in the studies I've helped publish and in every single large agency giving pre-hospital blood to penetrating trauma patients is that on average, the presenting systolic is in the 70s. They're hypotensive. At ED arrival, their systolic is 110, way above what we used to think of as a permissive hypotension threshold. And yet their mortality is dramatically higher than without blood. So I think we need to, and I presented this at a military presentation that I shared with you, Eric. I think we need to reevaluate the concept of permissive hypotension in a pre-hospital blood era. There's something about giving blood that improves the physiology of the patient in a way that they both need and can tolerate slightly higher pressure. So what's the endpoint? I think a reasonable pressure, 90 to 110. What about TBI? Probably 110 to 120 is probably more important to achieve. We know that from EPIC TBI. In kids, I think of hypotension based on the PALS guidelines. I don't agree with everything in PALS, but I love the calculation of 70 plus twice the age is the minimum systolic. Okay? You see that, you got to resuscitate. To what endpoint, Eric, should we go? So age 1 to 10, I would try to get them to 80 plus twice their age. That's a reasonable target pressure, 80 plus twice the age, or about 110 in a 10-year-old and over.
Sure.
Is that sound like a reasonable
yeah. I mean, I
threshold to
teach
you?
70 plus 2 times the age
as your minimum,
low, and then 90 plus 2 times the age. But 80 is, I mean, you're in that middle point.
I think it's a reasonable middle ground.
Absolutely.
For people to like have in their heads. So 80 to 90 plus 2 times the age is probably reasonable. Yeah.
So let's talk about shock index. That's one of the questions I get all the time in pediatrics, right? We have these definitive equal to or greater than 0.9 is equaling, potential bad outcomes. How do we look at that in kids?
And just to go back to some of the published data in adults, in all these pre-hospital studies, the presenting shock index is around 1.4, which is really, really high. And remember, shock index is heart rate over systolic blood pressure. Interestingly, I think of shock index as a way to bring pediatric thinking into adult medicine because it takes heart rate into account. The point of it is you encounter a patient whose systolic is 95, you think, that's not that bad. But with their heart rate's 130, something is wrong. Their shock index is way above. It's 1.2, 1.3.
Right.
That tells you something's wrong. This is true in sepsis, trauma, obstetric hemorrhage, GI bleed. What about in kids? I've practiced pediatric emergency and critical care for almost 30 years. And I have yet to find that calculating an age-specific shock index makes sense to me. Okay, so I'm just going to acknowledge and admit that. I'm about to publish a paper on this using the pediatric adjusted shock index, but I probably won't tomorrow in the trauma bay calculate it in my mind. I'll look at the heart rate and say, that's pretty high. And they're close to 70 plus twice the age. They're sick. I'm going to do something about this. Okay.
Right.
I'm just acknowledging my practical approach to pediatrics.
Yeah.
But there is evidence, and I'm about to, if the editors accept it, I'm about to publish data from my own center over hundreds and hundreds of kids that shows that the shock index is a super valid early indicator of shock. And if you act upon it, you're much more likely to have a survival than if you don't. It is a great early indicator of shock that needs urgent treatment with blood in a trauma patient. So I won't go into here. If you want to put in the show notes, we can put an article in there on how to calculate the pediatric adjusted shock index, which is weirdly called SIPA, shock index, pediatric adjusted.
Okay.
It's even too complex a name to remember. So I do think there's validity to it. I don't know that it's a practical tool that we can just use in the field every day.
Okay.
Does that make sense?
Yeah. Let's talk about, we're getting close to the end here, challenges to setting up a blood program. What are your thoughts on that? How do we overcome those?
You've outlined some of them already. I think one is, I'll just go back to, we're too close to the trauma center. It doesn't make sense to do this. Sure. That one, I think, should be put to rest. We showed in one of our other publications that is literally titled Minutes Matter, that each minute of delay in initiation of transfusion resulted in 10% excess mortality. Do we really believe that those minutes pre-hospital don't matter?
Wow. Yeah.
It's a paradigm shift that we have to begin thinking. We have blood available in this country to pre-hospital providers. Let's get it in their hands. So the first barrier is knowledge that it works. And I agree, more data are needed, published, but I think we have enough to say it works and we should be going for it. Number two are the cost and logistics. And I don't know how to overcome that yet. That's probably, as you would acknowledge, one of the biggest barriers. Is this is a lot for us. We have many things to focus on. How can we just choose this one and put all our eggs in that basket? Again, I would say it's worth it. It makes your agency better. It makes you better as providers. And costs will come down ultimately. I think as we begin to demonstrate that we are not only saving lives, but saving interventions in the hospital, if we can figure out a pathway to have the hospitals say, we'll use less blood here because you used it in the field. Let's exchange that with you. I think that will be an effective way to begin to help reimburse EMS providers for the care they provide.
That's a great point.
Blood banks still believe many that blood products should be administered in the hospital only and are reluctant to put blood into the hands of pre-hospital providers. As again, as Peter mentioned, Randy Schaefer, who's on our Spark team, is expert at this, former Army Lieutenant Colonel, stood up the blood programs in Iraq and Afghanistan, and is helping many agencies figure out the logistics of working with the blood bank, how to pay for it, how to exchange it, where you can exchange your near expired product with the trauma center, you waste almost zero. That's the goal. And I think that's what people should shoot for. Not everyone can do that. The training, definitely a logistics hurdle. The equipment that's needed, yes, adds cost. Every transfusion is probably going to cost you about $700 to $1,000 per patient when you take all equipment and blood products.
Is that packed red blood cells, plasma?
That's whole blood.
It's whole blood. Yeah. Whole blood's expensive.
Can't tell you the packed cells and plasma cost off the top of my head.
Yeah.
I do think the freeze-dried and spray-dried will lower those barriers as well. And then just the team, all the essential components of the team, the EMS chief, the administration, the medical directors together deciding this is something we want to do. And that's why I'm out there doing podcasts like this, speaking all over the country and all over the world as much as I can, trying to just change people's mind that, hey, this is the way we're going to improve care. And by the way, what kills more people than anything under age 45, kids and young adults, is trauma. Well, why are we not making this a priority? So reimbursement, improvements in reimbursement at a national and regional level will help. Many people are putting effort into that. But yeah, I wish I had better answers other than there are a lot of logistical hurdles, and let's work together to try to overcome them.
So last thing, let's talk about Spark. Tell us about that.
So Spark is an effort that arose out of several of the agencies that I've had the privilege of working with, including Peters, Palm Beach County, Juan Duchesne and Tom Dransfield, and Meg Marino down in New Orleans, several other South Florida agencies, Randy Schaefer, who I mentioned, and a variety of military personnel, all who have had the opportunity to experience the life-saving effects of pre-hospital blood and also have experienced those logistical hurdles we talked about. So he said, why don't we just start teaching a course where we comprehensively go over this. One, the inspiration, you're going to save lives, change the world. Two, the practical implementation in the field of a trauma assessment and resuscitation, hemorrhage control, blood product administration, airway, subsequent to circulation, not the ABCs, but the CAB approach to trauma care. And then three, some of the logistical hurdles, working with the blood bank, working with the surgical team in the trauma center. And the name kind of comes from a publication that was put out, an aspirational publication called Selective Pre-Hospital Advanced Resuscitative Care, meaning let's change the paradigm from rushing to the hospital and hoping the doctors are going to figure it out there, to having a pre-hospital resuscitation team, namely paramedics and nurses in the field, providing that critical care from the minute they encounter the patient. And the selective refers to, we can't do everything. We're not going to provide definitive care for someone who needs surgery, but we're going to stabilize them until they can get to that surgeon. And so we began teaching the course in Hollywood, Florida, a number of years ago, and we invite pre-hospital providers at all levels, physicians, EMS administrators, to come and hear the kind of comprehensive package of what it takes and how it can be implemented in your agency. So our next course will be at EMS World in October.
Indianapolis, yep.
In Indianapolis. You can find it on the pre-course menu, along with the Flight Bridge Ed courses, which I know you have many of. Yeah. And we expect a big turnout there. We've done maybe 8 courses now. You can look at our website, our emerging website, sparkacademy.org. And our mission is to help pre-hospital providers develop a vision for improving trauma care through effective hemorrhage control and resuscitation. And it's been a total privilege to work with that team to teach this course. And I hope it continues to grow, and I hope we can partner with you, Eric, in the future on rolling this course out to more providers.
Yeah, I would love that. I would love that a lot. I definitely think that, again, trauma season, I think the blood product administration question is, I'm asked that all the time. Love having experts like you and Peter and to share your knowledge. I really appreciate you traveling all the way here from Raleigh and coming to the studio. And do you have anything last to add?
One, a name I left out of the Spark course who's been a leader is Juan Duchesne, a former trauma surgeon at Tulane, now at the University of Mississippi. And he's been an inspiration to all of us as a surgeon, recognizing, no, I'm not the only one that can fix this patient's problems. You in the field can bring that patient a lot healthier to me so that I can do a better job of fixing that patient. And
Amazing.
so I've appreciated his leadership on this topic, and he's one of our founding Spark Academy members. And I think the concept that every minute matters is just the point I want to make, Eric. If every minute does matter, and it does, we have data on that, then we need to put every tool possible in the hands of our pre-hospital providers. And probably the most important tool that we have that's new to us is pre-hospital blood. And so let's figure out ways to improve resuscitation and as close to the point that we encounter the patient as possible.
Amazing stuff. Well, I will put his Mark's contact information in the show notes if you want to get a hold of him. Again, thank you for coming, and we will talk to you soon.
All right. Thanks, Eric.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.